case, I have actually split the HPI in two parts because it is essential to present the case in that manner. So maybe I would start with the chief complaint. Yeah, I would just wait for White to come on the screen. All right, let's go. Yes, so the chief complaint is loss of consciousness. And to give you a bit of HPI, we have a 21-year-old male who was going to his college through the bus. And after disembarking from the bus, as he was walking through the college campus, he suddenly felt lightheaded and then collapsed on the floor. However, he regained the consciousness shortly upon falling and was then immediately taken to the emergency department, where his pulses were barely palpable and were extremely feeble, and blood pressure was recorded as 90/50. He was then given oral fluids, after which his blood pressure returned to the normal. And this is where I would stop just to reflect a little bit, and then maybe I can give you next bit of data.
Amazing. What an incredible start. I think this is devastating to hear of somebody so young having this. And the deeper truth here is whenever we think an organ is dysfunction, here the brain, you have to actually recognize that organs can be dysfunction because of disease elsewhere. And I think this is best taught to us when we talk about pre-renal disease, where it's emphasized to us that the problem isn't in the kidney, it's a problem in the hemodynamics. And here, exactly the same, Kirtan is painting a story of the brain that he's linking to a problem with hemodynamics. So I would call this a pre-brain loss of consciousness. Why? Somebody has a brain problem, but we feel a pulse problem, and the brain problem goes away when the pulse problem is restored. So very quickly, you can go from, I thought it was the brain, but now I've realized it's a pulsus problem. And how we analyze that is we analyze the causes of transient hypotension, which is syncope, essentially. So with a fair degree of confidence, you can say this patient had syncope, and the confidence comes from assuming that your blood pressure cuff is accurate and your pulse exam is accurate. And that is not 100%. So you might have to go back into the other causes of transient loss of consciousness, which are the other S's. Seizure appears unlikely here because of the return to normal, sugar, hypoglycemia, or rarely the possibility of a TIA in the posterior circulation or stroke. So we're confidently in the syncope world, but that confidence is never arrogance. And so seizure, sugar, and stroke are still things we need to analyze. I'll give the mic back to you, Kirtan.
Yeah, sure. Actually, I forgot to mention the title because it's the best part of this case. It's a potentially fatal sequence. And now to give you a little bit more of HPI, on examination in the emergency department, the patient had few fading urticarial patches which were present on arms and legs. The patient then describes his experience that he has had such rashes before, but never has he suffered from syncope. To give you a bit of review of systems, the patient denies any insect bites or medication exposure or taking any herbal supplements. Patient denies having any sort of food allergy. Patient denies shortness of breath or choking sensation. Patient denies developing rash or syncope while exercising or exertion before in the past. To give you a bit of past medical history, on 2 occasions within previous 6 months, it has happened that after reaching the bus station from his home and while in bus, he developed widespread urticarial rashes, which resolved spontaneously within 20 to 30 minutes without any other symptoms apart from itching. As for the medications and family history, they are non-existent. Social history, patient denies alcohol, tobacco, or illicit drug use, and no allergies. And physical examination, apart from these rashes, is clear. There is no evidence of cutaneous stigmata, like any evidence of scarring or hyperpigmentation on arms or legs. And that's the end of Helicode 2.
Oh, wow, Kirtan. When we all grow up and you're one of the bestest diagnostician, then I will always say, I knew him when he was just starting out. Masterful presentation. And those namings are so fantastic. All right. So it gets more and more interesting. And I love the Robbie's approach, starting with anchoring us in loss of consciousness and syncope. And now we get additional information with what appears to be urticaria rash. So now I invoke like also our hypotension schema, like our approach to hypotension, and thinking about in this individual specifically, like kind of one of the causes of distributive shock per se, or hypotension, that is anaphylaxis. So what I'm worried about with this urticaria rash is this some type of an allergic reaction. And it's interesting that it happens every single time in the same situation, like when he's on the bus. So the question becomes like, is there any antigen or anything in that setting that causes his symptoms to present itself? So that tends to be like with urticaria, that tends to be like the most common etiology, thinking about anaphylaxis, especially in someone coming hypotension, the fact that he gets better with fluids. So, and a lot of sometimes anaphylaxis has bimodal response. So you get within the first minutes to an hour. And then again, I think I'll put to 12 hours or something, or 24. I don't specifically remember the timing of that, that you can have another reaction. So something to keep an eye on. And so in these situations, like epi is your best friend. So just keep closely monitoring him. There are conditions like I think like mastocytosis and other more etiologies that can also present with this. So something to keep in mind. But in most comers, think about anaphylaxis. Anything to add, RG?
Nada. Whoever looked closely at the skin exam may have saved this patient's life. I have to tell you, I'm kind of scared now because the number of people who have syncope who I don't take their clothes off to examine is actually not like, I don't think I've ever examined a patient closely for urticaria. So whoever did this, kudos to you. You might acknowledge the tip off that the patient gave you by them being itchy, but I would go back and say, well, sometimes we don't even allow the patient to get that history because we're so focused on the acute cardiovascular focus. So massive props to noticing this important clue. And I would be utterly disappointed if it's just a distraction. So I would take back my congratulations if you're trying to just fool us, but I don't think Kirtan would ever do that. All right, Kirtan, back to you.
Yeah, sure. So now talking about the labs, the patient's hemoglobin, WBC, platelets are all within the normal range. Electrolyte, including the comprehensive metabolic panel, are within the normal range. LFTs, RFTs, all are good. TSH, T3, T4 normal. HIV was non-reactive. ESR was also normal. And I guess that's all we did before we did another thing, which sealed the diagnosis. And as I told you, it's a short case. So I only have this much of data.
Amazing. Can I just ask one question, Kirtan? Was the two questions actually, was the diff on the CBC is also normal without eosinophilia? And
yes,
liver enzymes were also normal?
Yeah, liver enzymes are also normal, and the sodium and potassium were also within the normal range.
Perfect. Awesome. So I think, Shami, we should reflect together on this. And I can start us off by saying that I think in reality, you have to proceed with two parallel paths. I think the first is recognizing that the base rate of chronic urticaria, which this would be, is so high that a person would be totally vulnerable to getting a disease independent of their chronic urticaria. It's no different than you say somebody has chronic back pain and is here with chest pain. You might say, oh, that's aortic dissection because the patient has chest pain and back pain, but the back pain is incidental, unrelated. But if you're being systematic about assuming that they're related, I completely agree with you that we're probably going down the mechanism that there is vasodilation from an anaphylactic reaction causing distributive-like syncope and urticaria. And as Katarina mentioned in the chat, the other mechanism might be urticaria through increased vagal tone. So you can have vasovagal syncope and cholinergic urticaria. And while that makes a lot of sense pathophysiologically, I've never read it being a phenomenon where the same patients who get vasovagal syncope get vasogenic urticaria. I don't know if that happens to people. It seems so such an eloquent pathophysiological explanation. But you know what's interesting about this case is it probably the nature of the anaphylactoid reaction is unusual. It's unusual because it seems to be unprovoked by a food, medication, or a sting, which are the three most common. And that takes me into a space that you were dabbling in, which is the entities of anaphylactoid-like reactions. And these are mimickers of anaphylaxis, and touched on mastocytosis, which certainly is something to think about strongly. The funny thing about mastocytosis is it comes in two varieties, systemic or cutaneous, both of which you need to entertain here. But the other is infections that can do this. And when patients get BCG vaccinations, actually just saw this in the emergency room yesterday, a patient with cancer got BCG treatment for their bladder cancer, and they had a systemic allergic reaction. But probably more importantly for us to think about echinococcus and Mastocytosis, given presumably that this patient is from India. And then you can get all sorts of funny things like catamenial anaphylaxis, anaphylaxis to semen, and other things. So I think my inclination is to say, realistically, they may be true and unrelated because the base rate of cholinergic urticaria is very high. But given the focus of infection over malignancy always, I'd probably be looking for the possibility of an echinococcal cyst or recent exposure to raw food like Mastocytosis might do. And then proceed to, wait, does this person have the imaging findings of systemic mastocytosis? And then I would call Kirtan and be like, what did I miss? Because clearly there's something very fancy and esoteric going on. But I'll pass the mic.
No. Yeah, not at all. We were just doing what you thought. So we did the USC, we did the CT scan to make sure there was no evidence of hepatosplenomegaly or any bone lesions which could guide us toward the mastocytosis. Then we also did the stool ovine parasites test to make sure there were no parasites, and both of those tests were unrevealing. Then we decided that let's take another round of detailed history. So we asked that what exactly happened.
I interrupt you real quick? Sorry.
Yeah.
You know,
yeah,
I know
please.
you have to reveal the answer, and we can't proceed with the answer without.
No. I'm sorry. Actually, I will tell you one another piece of data before I will give you answer. Yeah, no worries. Yeah, sure. So what exactly happened on the day of syncope and other days in past when he has developed rest? This is what we were curious about. So he told us that he usually consumes the biscuits and coffee for his breakfast, and then he usually walks for about a mile, that is around 1.6 kilometers, to reach the bus station. In the bus station, after around the 10 minutes, he starts developing this rash and pruritus, and then on reaching the college, when he started to walk, he finally collapsed. So this is what exactly happened on the day of collapse. Now, when we ask the patient to remember, if he can, that what exactly happened on the past when he developed rash but didn't develop syncope. So there was any difference or not, that is what we were curious about. So he told us that on some days when he consumed the coffee or milk alone, it never happened. On some days when he consumed the biscuits alone, like let's say on Sunday, when he is not going to college, nothing happened. But on some days, when upon reaching the college, he ate the biscuits in cafeteria, still nothing happened. So like he walked, he took the bus, he went to the college and then ate the biscuits, nothing happened. But on those days, when he consumed the biscuits for the breakfast, followed by walking to the college on a hot or humid day, following that, he developed the rash. So this was the thing that I was keening on telling you, that a potentially fatal sequence, because the sequence is very important. He always eats the biscuit, then followed by exercise, then only this thing happens. Another way around, it doesn't happen. So maybe this can give you that clue.
I think this is a clue for Robbie, because I'm like, oh, is this something's happening there? I don't know. Archie, can you teach me?
I would only be learning through conjecture, honestly. I think well, actually, I haven't seen the chat, but it looks like Katerina called it. Katerina, do you want to unmute and tell us what you're thinking?
I wasn't thinking a lot besides what you just said. It took me through histamine and then the sympathetic nervous system or absence thereof. So yeah, I was thinking, was this in the summer? Was this in a really hot day? So looks like it, yeah. Everything, came together for him to have a cholinergic reaction.
I completely agree. I have nothing to add but to say that I'm now going to call Kirtan the biscuit detective because of his ability to get down to the bottom of this. So tell us what you learned and what the answer was.
Yes, so actually, as Dr. Costa mentioned, that we are also worried about the cholinergic area. But the only thing which was going against the cholinergic area was that usually in cholinergic area, we get the hives which are very small, kind of pinpoint, and they are not very confluent. And another thing that the patient tells us that whenever he does exercise, he never develops the rash, but it is only when he consumes the biscuit. And I mean, the biscuit has the wheat component in it. That's why. And after that, he does the exercise. That is only time when he develops the rash and this anaphylaxis. And let me tell you, this is me. This is my case. So 3 years back, when I was in my medical school, as you know, that there is a website known as medscape.com. And on Medscape, we have various clinical cases and fast 5 quizzes, which is available free online to everyone. I recommend highly to all the students to do that. So on that, I was reading, there was a fast 5 quiz on urticaria. And in that, one MCQ was there that, patients sometimes develop urticaria after the food. And is there necessary to have a sequence? I mean, what if patient exercises first and then consumes biscuit? Would it lead to anaphylaxis? The answer is no. But if you consume the biscuit and then you do the exercise, then it will lead to anaphylaxis. And actually, when I read this quiz, I already had 2 past episodes. So now I got to thinking, that let's try an experiment. So on that particular day, I decided to eat the biscuit and then go to the college. I never knew that it would reach to this stage, anaphylaxis. I just imagined that I would get rash and that's it. So it was experiment, but I'm glad that I didn't fall on the floor. So the final diagnosis is food-dependent exercise-induced anaphylaxis. So this is an entity which is known as FDEIA. And as I told you that the sequence is the key, that food has to be followed by rise in temperature or exercise and not the other way around. And the clue here is that when we exercise, endorphins are released. And we know that endorphins are analogs of the morphine. And we know that in the clinical practice, morphine is one of those drugs which is known to cause the mast cell degranulations. So endorphins, which are analogous of morphine, which are released by our body during exercise, can do the same thing. But then what is the association with the wheat? So here is the thing, that intestinal permeability sometimes increases during the exercise, and even the tissue transglutaminase enzyme, which we kind of see in celiac disease, it kind of get activates during the exercise. And since the permeability of intestine is more, now the wheat molecules like gliadin and everything will have access to the mucosa, and they will bind to the IgE, and they will be able to degranulate the mast cell. And always there has to be a latent period. That's why when I try to walk from my home to the bus station, it takes like 10 to 20 minutes. Till then, nothing happens. But when I get to the bus, till that time, IgE complexes have time to reach the mast cells and kind of, degranulate them. So this was my hypothesis, of course. So then I consulted my residents and my attendings. They told me that, Kirtan, you should do allergy test and then see what happens. So they did the allergy test. They did all the things about mastocytosis. And in the end, there is the conclusion that I think FDEIA is the correct diagnosis, food-dependent exercise-induced anaphylaxis. And in fact, just a couple of days back, I had this episode another time, and this was during the night, So I thought that now we have winter in India, around 20 degrees centigrade, so I won't get it. And I just consumed the biscuit and was taking a stroll in the park, and I developed the urticaria. But I am sure that it didn't reach to the anaphylaxis stage, so I'm thankful for that. So yeah, this was the case, FDEIA.
Kirtan, I'm going to start calling you Sherlock from now on. And can we just play off the biscuits for now? We need you, Kirtan. You're amazing, my friend. Thank you so much for sharing this. Definitely, I learned a ton, as I always do, from you. And please be careful and take good care of yourself. And no more flirting with anaphylaxis, please. And yeah, and the other thing that I was going to quickly reflect on is like so interesting, just thinking about like the connections in our brain and sometimes like how things doesn't click. Because I remember hearing, Kat, you're awesome. So good to hear from you about like cholinergic urticaria in the setting of like mimicking vasovagal syncope, and like in someone who like had the same reaction to spicy food because they both stressors. But as we were talking about it, I was like, oh yeah, I don't know what's going on here. And then Kat, I was like, and then Kat started talking, and I'm like, oh yeah. So medicine is a team sport. I'm grateful for you all. RG, any thoughts?
I don't know what to say. How are you supposed to reflect to that? Kirtan, do you have any family members left that you haven't presented on VMR?
Yes, my father. Actually, my father hasn't developed anything so far, and I hope that it doesn't. But if it does develop something, then I will definitely present it.
No, we had enough. We've had enough. No more illness in your family. Done. I love it. I think Katarina or somebody just said the real VMR family is your family, my friend. They've been featured on. I now know a way to reduce your blood pressure with this mechanism, and probably also a way to increase your blood pressure by just putting a biscuit in front of you and seeing you panic about the possibility of it. So I don't know what to say. It's such a pleasure to have somebody who's so willing to bring us into their lives in a very intimate way. Now, these are people you love and care about, including yourself. And thank you so much for, we usually thank the case presenter for allowing us to learn from a patient's case. And I think the case presenter is the patient is always a special treat. So thank you. I really, really enjoyed this case. And ironically enough, we'll probably have something that that would be along the biscuit family after this VMR, just to celebrate your presence. Thank you.
No biscuit for you, Kirtan. Now I know.
Yeah, thanks again for the opportunity, friends.
All right, Rafa, take us home, my friend.
Oh, so thank you, Kirtan. Another incredible case. And yes, the last time that I was with Kirtan, he actually presented a case about his mother. So thank you, Kirtan, for another incredible case, and stay away from biscuits, please. So we had this patient with loss of consciousness, and the Rabi reminded us that to think about the 4 S's: syncope, sugar in the form of hypoglycemia, but also seizure and stroke. So since this is a young patient, stroke would be less likely unless there's a background like a hypercoagulability disorder. Let's say that this patient had nephrotic syndrome, for example, where there is loss of HT3 in the urine, leading to hypercoagulability disorder. And then when it comes to syncope, there's this transient hypoperfusion to the brain. It's also important to distinguish seizure from syncope. And there's this way that I really enjoy when studying about that. It's the tongue bite. It has a low sensitivity, but high specificity to seizures, especially if it's lateral bites, because sometimes you can have frontal bites with syncope, but this is less likely. And then when it comes to syncope, there are many etiologies that you could think of. For example, reflex with the vasovagal syncope, where there's increased parasympathetic tone. This patient also refers from prodromal symptoms like vision atelolaemia, diaphoresis, nausea, but also there is orthostatic hypotension leading to syncope. So it's always great to check the blood pressure of the patient, supine and on foot. And then we can be seeing that in, for example, when patients take certain medications like alpha-1 blockers, but also neurodegenerative disease like Alzheimer's, Parkinson's. Also, another cause could be cardiac, which is very worrisome, like arrhythmias, or structural cause like aortic stenosis, pulmonary embolism, hypertrophic cardiomyopathy. And then you see this patient had hypotension associated with rash. And Charmaine reminded us to think about anaphylaxis. This is a distributive shock. This is the only type of shock which has actually a low systemic vascular resistance. It can also be seen in the case of sepsis and CNS injury. And like Charmaine reminded us, epinephrine is your best friend here because it has bronchodilator and vasoconstriction properties. And then we saw that this patient actually had a food-dependent exercise-induced anaphylaxis. The sequence is key here to differentiate from cholinergic urticaria, which is part of the differential diagnosis. Usually food is followed by a rise temperature and exercise, not the other way around. And weight is the most common food involved. And exercise leads to the release of endorphins with mast cell degranulation leading to the symptoms that this patient had. In this case, Kirtan. So thank you, everyone. I hope everyone had a good time, and I hope to see everyone tomorrow.
Boom, Rafa. Hiya.